Buenos días a todos. Estamos un poquito atrasados, así que vamos a arrancar con la conferencia del Dr. Zoghbi. Tengo el agrado de presentarlo. Creo que no precisa mucha presentación, pero el Dr. Zoghbi es el jefe de cardiología en el Hospital de Houston Methodist. Es un gran referente en el área de cardiología, de ecocardiografía, de imagen cardiovascular. Ha escrito más de 350 artículos originales y ha participado en la coordinación de guías de práctica clínica que todos utilizamos. Fue presidente de la Sociedad Americana de Ecocardiografía y fue presidente del American College of Cardiology. Tenemos el gusto y el agrado de que hoy nos brinde su generosidad, una charla. Es una persona además muy bondadosa. Así que, bueno, esperemos disfrutar esta conferencia. Un aplauso.
Thank you, Dr. Ramos. It's a pleasure to be here. As I told you, I was very impressed, actually, with your country and its progressiveness, actually. I mean, your hospitality is also very overwhelming, and I truly enjoy being with you and discovering your beautiful country and your beautiful city. Okay, we're going to talk about aortic regurgitation, and I was asked, which area do you want me to emphasize? Among the valvular heart disease, this is really a significantly changing landscape of aortic regurgitation. And this is what I wanted to share with you, because we usually emphasize aortic stenosis, but there are quite a few things that are changing in aortic regurgitation. So if we put in context the burden of valvular heart disease, this is the incidence of valvular heart disease, be it mitral or aortic. Notice one thing, that the incidence of such diseases increase significantly with age. Above age 55 or so, it is rather exponential. May not be the same necessarily for aortic regurgitation, because as opposed to aortic stenosis, the vast majority of aortic stenosis are either rheumatic or degenerative. But here in aortic regurgitation, you can have a significant incidence of other diseases that affect closure of the aortic valve. One is bicuspid valve disease, and the other is aortic root disease with Marfan, Ehlers-Danlos, and other connective tissue diseases. These are the various valve pathologies: normal, a bicuspid valve with some calcification, rheumatic, and a degenerative aortic stenosis and disease. So this landscape is changing, because when I trained many years ago, we didn't have too many technologies for us to assess aortic valve disease. We had simple echocardiography with early Doppler, and you had to go basically to cardiac catheterization with angiography to be able to understand how severe the disease is. Nowadays, we have echocardiography with 2D, 3D, transesophageal, cardiac MRI, cardiac CT. We have metabolomics. We have many things that we could use without being invasive to our patients. And the interest in aortic regurgitation, as you could see here over time, these are publications, significant increase in interest and also contributions to what we need to do in patients with aortic regurg. Just like any valve disease, there is an acute phenomenon and there is a chronic phenomenon of aortic regurgitation. And acute regurgitation, usually endocarditis or type A dissections or traumatic, they're quite consequential and at times difficult to diagnose, because the patient is very acutely ill. Aortic regurgitation murmur may be absent. You may have low systolic pressure, and even with echocardiography, color Doppler may not be very impressive. The jets may be very eccentric and could fool you. So, believe it or not, continuous wave Doppler is very helpful in those situations, as opposed to the chronic situation where, as you could see there, at end diastole, there's almost no gradient between aortic diastolic pressure and ventricular end diastolic pressure, equalization almost, which tells you that LVEDP is very high. That's why these patients are so sick, and aortic pressure is way down. Now, in a chronic situation, in chronic aortic regurgitation, the differential diagnosis is longer than aortic stenosis per se. And I think you have to consider those when you see a patient with significant aortic regurg. Acquired leaflet abnormalities, obviously, we talked about it already, but importantly to emphasize the congenital abnormalities, the genetic abnormalities that can affect the aortic root in addition to the aortic valve. And here on the right side, you have examples of nice bicuspid leaflets, aortic root aneurysm basically, and some calcific aortic stenosis with concomitant regurgitation. This is rather simple, the pathophysiology of why chronic severe aortic regurgitation can have a deleterious effect on outcome. Early on, the ventricle starts adapting to the volume overload, and remember, aortic regurgitation also has a pressure overload situation. It's a combined volume pressure overload as opposed to mitral regurgitation, where it is mostly an aortic and a volume load situation. And gradually the ventricle enlarges, gets more hypertrophied, and ultimately fails. And for us as clinicians is to diagnose it properly and at the same time intervene on it properly, not too early, not too late, and to try to preserve ventricular function and overall good outcome. The latest version of the guidelines are the 2021 ACC-AHA guidelines, and these are the drivers of intervention in patients who are rather asymptomatic. So number one is the severity. We usually talk about severity of aortic regurgitation with echocardiographic measurements, and the question, are they reflecting severity accurately? And you'll see some data telling us that we may be a little too late and severity may need to be adjusted. Two is, what are the parameters that we use to intervene, or at least red flags for us to intervene? The ones that are published are rather simplistic, at least in my opinion. It's ejection fraction and a linear dimension as opposed to a volume dimension. So do we have new remodeling parameters to consider for prognosis? And these are important for the patients that you see. And last, and I will emphasize it less, is aortic valve repair and the newer adaptation of TAVI for aortic regurgitation as opposed to aortic stenosis. So a few things, and I know most of you, practice, general practice, and for assessment of aortic regurgitation, what do we use? These are, the latest guidelines from the American Society of Echocardiography and Society of Cardiac Magnetic Resonance that I was privileged to chair back in 2017. This is an update from 2003, 14 years ago, before this one was the first guideline. And what's in this guideline? It tells us few things. One is we emphasize an integrative approach in addition to identifying what is the underlying problem, the underlying mechanism causing the regurgitation, because it will influence how do we treat these individuals. There are also recommendations on when to use transesophageal, important role of cardiac MRI, and I know you have such technologies here, and the challenge of coexisting valvular heart disease. So for aortic regurgitation, this is an adaptation of the Carpentier classification. Simplistically, we always look at the aortic valve per se structure, in addition to the structure of the aortic root that is influencing the coaptation of the leaflets of the aortic regurgitation, the underlying mechanism of aortic regurgitation. From assessment of severity point of view, for those of you who practice echocardiography, these are the parameters of severity that really have not changed significantly from 2003 guidelines. So we look at the underlying mechanism. We always look at LV enlargement. Remember, this is chronic aortic regurgitation as opposed to the acute stage. One thing to remember, you won't have significant aortic regurgitation if the LV dimensions, size, volumes are normal. Remember also that you have to adapt, these measurements to, or index them to the body surface area or height of an individual. Color Doppler is very important in these situations. We always look at the three components of the jet: diastolic retrograde flow in the aorta. I do hope that you measure regurgitant volume and regurgitant fractions when needed, and a pressure half time, which is actually the least accurate among these measurements, as you will see. So color Doppler, these are the three components of the jet: flow convergence coming into the vena contracta, which is the smallest area of where the non-coaptation occurs, and then reflection of what happens to the jet in the LV outflow tract. And our issue with color Doppler is not the central jets, as you can see very nicely, and you can do that. The issue is when you have eccentric jets, when you have aortic valve prolapse, prolapse, or a flail. You could see it there, but the jet is so eccentric that it will give you problems assessing it. At times, you can still measure the vena contracta, but your usual measure of what happens in the LV outflow tract could be very misleading. It will usually is very small. So in eccentric jets, some reliable indicators are still vena contracta, flow reversal in the aorta, quantitation of regurgitant volume, and LV size. Less reliable, certainly, and can be misleading, a jet width of the LV diameter, and area of the jet in short axis, and adequate continuous wave Doppler. For those of you in echocardiography, like in this case, for example, the best way of getting a continuous wave Doppler measurement is not from the apical window, is actually from the parasternal window in that direction of the jet per se. And you could quantitate regurgitant volume and regurgitant fraction. You compare what goes out in the LV outflow tract to a right ventricular outflow or a mitral inflow to quantitate regurgitant volume and regurgitant fraction. As you remember, in the guideline, we have an algorithm to try to help you, and the algorithm separates them into some solid areas of mild regurgitation, severe regurgitation, and in between where we're really not sure, you may be able to quantitate and classify these individuals into mild, moderate, and severe, or even grade 1 to 4. And we recommend usually to go further with advanced imaging if you're unsure about the severity, mostly because it's important to have a feel for how severe the regurgitation is, and you have to be very aware of limitations of eccentric jets, just like I mentioned to you. Now, a few things, these are from the guidelines here, but these are the big boxes of specific criteria for severe regurgitation, and a few questions we had in mind over the past few years. We gave you these criteria not knowing the comparative accuracy of each. So there are a few questions that we like to answer. What is the comparative accuracy of these criteria? Let's take a look on the right side. Is the vena contracta or central jet more important than pressure half time or more important than flow reversal? How accurate are they? Should we think about a hierarchical approach? Which ones do you emphasize most? Which one you should be aware of and maybe some limitations? And do we need all these 6 criteria? Because by the time we wrote the guideline, we did not have answers to these questions. So what we did, that actually was published, earlier this year, just actually a few months ago, is we had an opportunity to compare individuals with echocardiography to near simultaneous cardiac MRI. And we asked these questions. What is the accuracy of these components that we mentioned to you? Interestingly enough, color Doppler and size of the ventricle are probably the most important. They're specific and at the same time sensitive enough. So color jet width as well as vena contracta are very important from a color Doppler point of view, and size of the ventricle, meaning the larger the ventricle, obviously the more significant regurgitation there is. The others are still important. They're specific, but not as sensitive. An example for such is I could have a patient with severe regurgitation who does not have a retrograde flow in the aorta. I can have severe regurgitation if my pressure half time is rather normal. So if you get specific, yes, but you may not be sensitive to those situations. The others are both specific as well as sensitive. And the combination of color Doppler and LV remodeling is sufficient, actually. The others are helpful to consolidate this. And this is the central figure that was published in JACC Imaging. And you have the reference there for you to be able to take a look at it and understand it. So that's number one. Number one is we could have a hierarchical approach in our criteria. Probably the most important are color Doppler and size of the ventricles. The others can be helpful, but not sensitive as we'd like them to be. The other question is, in the guidelines, ACC, AHA, European Society, American Society of Echocardiography, is we treat severity similar in aortic regurgitation compared to mitral regurgitation. And should they be similar? Meaning, let's say, for severe regurgitation, a regurgitant volume greater than 60, a regurgitant fraction greater than 50%. But we know these two diseases are very different. Mitral regurgitation is a pure volume overload. Aortic regurgitation is volume as well as pressure because the ventricle is pumping to the aorta, which has high pressure. And indeed, we're able to demonstrate that these two entities are very different, and therefore our criteria probably should be different. Take a look at this from a publication from our institution about 3 years ago. If you have a regurgitant fraction above 30% or so on average, the ventricle of aortic regurgitation in green remodels much more than ventricle of pure mitral regurgitation. So you have a larger ventricle for the same degree of regurgitation in diastole as well as in systole, more LV mass in aortic regurgitation above 50% or so, and ejection fraction we know that it is, stays flat or decreases with aortic regurg as opposed to mitral regurgitation where, it is higher. The outcome of these patients followed for about 2 years or so, interestingly enough, about 20% underwent aortic valve replacement based on symptoms or LV remodeling, and about 40% underwent AVR did not meet the definition of severe AR by current guideline. So if you take a look at the ROC curves of these patients, the ones in circle are the current guidelines from ACC, AHA, and European Society of Cardiology, and the ASE. So they're very specific, but not sensitive enough. What means to you is the best cutoff is somewhere in the 30% or 35 ml, 40 ml, which means that the usual grade 3 aortic regurgitation is actually quite significant. Don't underestimate the severity of such patients because ultimately they get symptoms or they remodel significantly. And this is the Kaplan-Meier curves of these patients, and our suggestion is to bring down 10% for each grade and maybe 10 ml for each grade to tell you the severity of regurgitation. So be careful, particularly about grade 3 regurgitation classically, because they may have symptoms that you may need to intervene on, and they may actually progress. And, we're trying to figure out whether these are the same for echocardiography, so obviously these were done with cardiac MRI. The other question to you, as we posed, is we look at cutoffs for LVEF of 55%. Remember, in the previous guideline was 50%. And fully, appreciative of that change because patients between 50 and 55% did not do as well. And the other is an end-systolic dimension greater than 25 millimeter per meter squared. And these are some of the data that were acquired more recently after the guidelines, which go hand in hand with the guidelines. If you take a look at ejection fraction, be it either volumetric or with linear dimensions, at 55%, certainly a good cutoff. And the question, there is a recent publication from Mayo Clinic with an editorial from myself, between 55 and 60%. I'm really not sure yet that we have to push it to 60%, but I think 55% is certainly very important. You could use global longitudinal strain as a 15% cutoff, right, which is almost a cutoff of 55% in ejection fraction. And this is the mortality risk and end-systolic LV diameter index. This is important for you, meaning guidelines are in red at 25 millimeter per meter squared. And there is a higher risk actually of death and other issues between 20 and 25. So for the particular patient that you're concerned about, maybe an older individual that you need to intervene, somebody who has maybe symptoms or other things, you can consider the between 20 and 25 millimeters per meter squared, for intervention on these patients. And actually this was borne out by a recent publication, again from our institution, but it's a collaborative registry from multiple institutions, from Duke, Piedmont, Atrium Health, and Houston Methodist, looking at these, that the cutoffs for remodeling by cardiac MRI to outcome is similar to the one I showed you before. A cut point of aortic regurgitant volume of 47, an end systolic dimension of 4, an end diastolic volume index of 109 or so milliliter per meter squared, and a regurgitant fraction of about 43%. And this is the central illustration from that publication, which was about 2 years ago now, for your reference to take a look at that. And we know with cardiac MRI, there are other factors beyond echocardiography that can be used. One is LGE, which brings a worse prognosis almost any time, any disease that you have late gadolinium enhancement, it imparts a worse prognosis compared to those who don't have that. And the question is, if you intervene earlier on such patients, do you improve them? This is retrospective data that says yes, but I think we need prospective data to tell us whether we should intervene on such patients. And the last one also is, from a cardiac MRI point of view, is extracellular volume index by cardiac MRI, telling us that in those individuals who have much more interstitial fibrosis, as measured by cardiac MRI, they fare worse compared to the others, more diastolic function, more heart failure down the line. So we could use these in patients to try to maybe identify an earlier intervention if appropriate on such patients. And last is aortic valve. What do we intervene? When we decide to intervene on such valve, what should we do? And I would stress the fact for you is that if the aortic valve is repairable, and the question of repair of the valve is obviously you have to have a great surgeon to be able to do that. Number two is that imaging is very important to help the surgeon or the interventionalist decide of what best to do. So we have to give them the measurements, whether the aortic valve itself is calcific, too thickened. If it is much more symmetric, it usually is much more amenable to a repair procedure. And if you have a problem with the aortic root per se, there's a David procedure nowadays that can be used in appropriate hands. And you could see here that if you do the aortic valve and aortic root repair in green is much better prognosis than if you do a composite graft, biologic or mechanical valve repair. And last is, the latest trials on TAVI in aortic regurgitation. And this is data from the JANA valve, the ALIGN AR trial that was published in Lancet last year, telling us that, number one, it is feasible to do that. These are specially devised valve, the JANA valve and the J valve for aortic regurgitation. The symptoms improve the remodeling of the ventricle. You have significant reverse modeling. It's not yet approved in the United States for such, but I'm pretty sure at some point in time it will be approved. So in conclusion, few thoughts. One, importance of assessing aortic valve and aortic root structure and the mechanism of aortic regurgitation. For severity assessment, this is some of the adjustment, and I think they will bear out most likely in some recommendation changes in the international guidelines. The regurgitant volume and regurgitant fraction are likely lower than the guidelines currently. For each severity grade, lower by about 10 milliliter for regurgitant volume and 10% for regurgitant fraction. And the evolving prognostic markers in asymptomatic individuals for you to consider. Obviously, decisions on patients is a shared decision-making in addition to as much data as possible. Consider these in asymptomatic individuals, an end systolic dimension of greater than 20 millimeters per meter squared, and systolic volume greater than 43 per meter squared, and this is by both echocardiography and cardiac MRI. Presence of LG and MRI, extracellular volume index 24, and GLS greater than 15, less than 15. And in interventions, I would implore you to, in appropriate patients where valve repair can be done, and these are chronic lesions, send them to a place where they could do a valve replacement or aortic root, repair to avoid, number one, anticoagulation and issues down the line, right? And hopefully have a better survival. And I think the data is very promising for TAVI in such individuals. Thank you very much for your attention and for the invitation to share this with you.